All right, let's lock this in. Pericardial disease, it's really just a game of three states: fire, pressure, and cage. That's it. Okay, rapid fire. You see fire? That's acute pericarditis. You're looking for that classic lean forward pain, the diffuse ST elevation, you hit it with NSAIDs and colchicine. Then there's pressure, cardiac tamponade. This is an emergency, people. You're looking for Beck's Triad, muffled heart sounds, JVD, hypotension, plus that pulsus paradoxus. The move? IV fluids and get that needle in for pericardiocentesis. Finally, the cage, constrictive pericarditis. The heart's in a concrete box. You've got Kussmaul's sign, that paradoxical rise in JVP and inspiration, and you hear a pericardial knock. Surgery is the only real fix. Oh, in special cases, if it's uremic, dialyze. Late post-MI, that's Dressler's. You master this trio, you follow the tree, you save the patient. Let's go! Now, before we finalize that decision tree, we must cover our mandatory international medical disclaimer. This content is for educational purposes for international boards only. It is not and should never be considered medical advice. Always consult official guidelines and a specialist physician for any clinical decisions.
So Sarah, we've got the concepts down: the fire, the pressure, the cage. But you know how the board exams are? They love to throw you a curveball with that next best step question.
So let's paint a picture. You've got a patient, classic pleuritic chest pain, diffuse ST elevation all over the EKG. But their blood pressure is tanking at 80/40 and their neck veins are bulging. What is your absolute first move?
Whoa, hold on. The first move is absolutely not NSAIDs, Dr. Collins. I know you see all the signs of pericarditis, but that hypotension and JVD, that tells you this is escalated. They've crossed the line into cardiac tamponade.
In this exact scenario, the next best step is to get an echocardiogram stat to confirm the fluid. Then you immediately bridge with intravenous fluids while you prepare for a pericardiocentesis. You have to remember, you never, ever treat the inflammation while the pressure is killing the patient.
Exactly. Stability first, always. Now, let's switch gears to the chronic side of things. We've linked the 2015 ESC guidelines in the description below, and they are crucial for telling the difference between restrictive cardiomyopathy and constriction. So, Sarah, using those guidelines, if you hear a high-pitched sound in early diastole and a chest x-ray shows calcium outlining the heart, what's the definitive next step?
Well, that's textbook constrictive pericarditis. The definitive next step is to evaluate them for a pericardiectomy. Sure, you can give diuretics to help with symptoms for a bid, but you can't medicate away a concrete shell around the heart.
And hey, here's the top score version of that question. If that same patient with the concrete heart is from a developing nation and they've been having night sweats, you don't even hesitate. You initiate anti-tuberculosis therapy right away.
That is outstanding clinical integration. Perfect. Okay, let's wrap this section up with the drug rules. Sarah, tell everyone, why is colchicine the undisputed board king of pericarditis management?
It's simple, really. It's because it is the only drug we have that is proven to reduce recurrence. It doesn't matter if the pericarditis is viral, idiopathic, or even Dressler syndrome. You add colchicine for 3 months to make sure that fire stays out for good.
But, and this is a huge but, you have to stay away from steroids. Unless the patient has an underlying connective tissue disease, you avoid them, because steroids paradoxically make recurrence more likely. It's a classic trap.
Perfect. So let's review. The triad is simple. Pericarditis is inflammation. Tamponade is pressure. Constriction is stiffness. Sarah, it's time. Let's lock in the final decision tree.
Fire is lean NSAID.
Pressure is Triad. Needle.
Cage is knock surgery.
Dr. Collins and Sarah, colchicine for the stay recurrence.
Fluids for the fill. Guides for the skill.
All right, beautiful. Let's bring this all home and connect it back to the real world.
So here's our question of the day for all of you on the front lines. Which of these pericardial giants do you find is tougher to diagnose in a real clinical setting? Is it the subtle come-and-go friction rub of pericarditis, or is it that elusive pulsus paradoxus of tamponade? Drop your experience in the comments below. We'd love to hear it.
Finale locked. You have officially mastered the heart's protective shield. And that is our deep dive on pericardial diseases. Make sure you subscribe for our next masterclass, where we're going to be tackling congenital heart diseases. Let's keep encoding.